Good afternoon, all the students present here. Good afternoon, sir. So is the extended EDIC Part 1 crash course, and today we will be covering domains like nutrition and general topic. So, it's up to you. You can start. And aspirants, this is going to be a very interactive session. You can also unmute your mic or you can also write in the chat box. Thank you. So you can start the lecture.
Yeah. So, good afternoon, student. Today we will talk about metabolic and nutritional uh, domain. And so there will be some K type and some A type question. Uh, Now, nasogastric tube and nasojejunal feeding tube. So it's a K type question. You will put your answer in the chat box and yeah. So enteral nutrition is associated with reduced risks of bacterial and toxic translocation, gastric residual volume 200 ml, increased risks of reflux, aspiration, and feeding should be stopped. NG feeding is indicated post gastroesophageal surgery. NG tube should not be passed further more than 65 centimeter and NG tube are easily placed. So, student, please give your answer. You can use the chat box. The answer is enteral nutrition associated with reduced risks of bacterial and toxic translocation, gut in it maintain gut integrity. There are large style on the gut microbiota, and it has been found that if the patient is in NPO status for more than 48 hours, there is a breaching of the gut microbiota, and which help in translocation of the bacteria in the system. That's why there is a production of infection or inflammation. And regarding the large volume gastric residual volume 200 ml, whether you will stop or not, the guideline says that if the gastric residual volume more than 500 ml, then you can pause the your next feeding and you can add some inotropics, some prokinetic drugs. The drug of choice here is the erythromycin, but remember, we use Reglan, but metoclopramide is the drug of choice as per the European standard. Next, coming to NG feeding is indicated post gastroesophageal surgery. Yes, it has been recommended that early feeding, even the post-Whipple surgery or post-gastric gastrectomy, and also in acute pancreatitis, early gastric feeding is recommended. Then NG tube should not be passed further more than 65 centimeter. So here it is recommended that if you are entering more than 65 centimeter, there is a risk of complication. So it is better not to go beyond 65 centimeter. And NG tube is easily placed. No, not always. And regarding the confirmatory test, there might be asked what will be your confirmatory test for whether this one in the right position or not. So that will be the chest X-ray is the confirmatory position. Now coming to the next regarding the critical care nutrition, the commencing enteral nutrition within 24 hours of intensive care admission is associated with significant reduction of mortality. Yes or not? And trophic feeding compared with full feeding during first week of intensive care admission is associated with worse functional outcome in patient with acute lung injury. Option C, during the early phase of the critical care, protein intake 0.5 per kg per day is recommended. Selenium supplement is no benefit in the septic patient, and the timing of parenteral nutrition description remain uncertain. So, student, you can put your question, your answer. So, you are saying first one is the Shufokazi Dalkin said that for option A is false, option B is right, option C is false, and then two right. So actually, the enteral nutrition within 24-hour intensive care association with significant reduction mortality. No. Yes, you are right that enteral nutrition within 24-hour initiation, it has no mortality benefit. Uh, though there is it has been shown that the early enteral nutrition, which reduces the calorie deficit, which reduces the morbidity, but there is no mortality benefit. Tropical feeding compare full feeding during first week of intensive care admission associated with worse functional outcome patient with acute lung injury. No, it has been shown that the patient there is the question is little tricky. The statement is little tricky. Worse functional outcome. No, tropical feeding is now it's recommended that when you are first you calculate your calorie requirement of the patient and then calorie and protein requirement and then try to replacement this requirement first. uh, it should be 25% of the total requirement in the first day, 50% in the second day, 75% in the third day. Then you go for a gradually incremental dose. It is a this is called trophic feeding. So it has been found that if you go by the trophic feeding in gradually incremental dose, it reduces the complication like your refeeding syndrome. What happened in the refeeding syndrome when the patient is fasting, because most of the critically ill patient, they are to some extent they are fasting, their electrolyte abnormality is there, and when you are putting the full diet on them, what happened? There is a severe insulin surge, and this severe insulin surge causing the potassium ion to be going to the shifted to the extracellular fluid to intercellular space. So what happened? There is a severe hypokalemia. This hypokalemia can cause cardiac arrhythmia and it might cause the cardiac arrest. So that's why it is recommended not to give the full feed in the first day. So what are the scale or what are the scoring system to identify the malnutrition is the well recommended and well accepted scoring is the Nutrit score or the mass score, or in a crude method is arm circumstances. You can measure and you can find out the calorie deficit of the patient and try to fulfill within the 4 to 5 days. During early phase of the critical care, protein intake 0.5 gram per kg per day is recommended. No, it is protein is always recommended 1 gram per kg per day, And in certain circumstances where protein intake you have to increase, like if your patient on dialysis, if the patient on dialysis, you have to give extra protein. But when the patient is in AKI or sepsis situation, you can you can't reduce the protein intake, but you can continue 1 gram per kg per day. Regarding the selenium supplement, is showing that selenium supplement is of no benefit on the septic patient, but there are certain situations where the trace element has a good effect. One is your selenium in septic shock, other is glutamine in the burn. So you have to see the recommendation on your micronutrient supplement. You can follow the ESPN guideline, uh, which is standard for this exam. So you download the ESPN guideline and you quote all the recommendation. You will get question from there. Now coming to the timing of parental nutrition prescription remain uncertain. The option is true. Why parental nutrition remain uncertain? So the parental nutrition is not recommended initially, but if your patient not able to maintain the nutrition by enteral route, then you can shift it to parenteral nutrition. Or parenteral nutrition not advise patient who expect to have soft critical care stay and likely resume intake within 5 days, and that's why it is very uncertain. Now, regarding the nutritional requirement, Parkland formula used to predict calorie requirement. 25 to 30 kilocalorie per kg estimated daily energy requirement. The topical daily sodium requirement is the typical daily sodium requirement is 0.7 to 1 millimole per kg per day. Typical daily carbohydrate requirement 3 to 4 gram per kg per day, of which 60% should be glucose in the parenteral nutrition. And typical daily calcium requirement is 0.4 millimole per kg per day. So please put your answer. Mm, please put your answer. Okay. If T T T. Acha. Yes, Parkland formula is not predict the calorie requirement. Parkland formula is for the burn patient fluid resuscitation, the fluid requirement. So what is the formula to predict the calorie requirement? Is Herrick's uh, this is Harris Benedict equation, which is used for calorie requirement. The estimated daily energy requirement is around 25 to 30 kilocalorie per kg per day. The energy requirement alter depending upon the clinical state, like if there is a fever, or if there is a fever causes increased metabolism, so the calorie requirement increase. The potassium daily requirement, the typical potassium daily requirement is 1 to 2 millimole per kg, whereas sodium daily requirement is around 2 to 3 millimole per kg. The typical daily carbohydrate requirement is 3 to 4 gram per kg per day, and which is 60% should be glucose in the parental nutrition, and 40% energy should come from the lipid. And typical protein requirement is depending upon the illness 1 to 2 gram per kg per day. The typical daily calcium and magnesium requirement is 0.1 millimole per kg per day. So next is regarding the parental nutrition in critically ill patient. Patient with enteral feeding running at 40 ml per hour within 4 hourly aspirate more than 200 ml deemed to be failing enteral nutrition, or daily calorie intake should be 100 to 130% of the patient calculated daily energy expenditure. Parental nutrition can be administered peripherally. Approximately 1 gram per kg per day. Nitrogen is required. Copper, zinc, selenium, trace element are present in commercially produced parental nutrition solution. So your answer? Yes. Answer, please. So here, the patient enteral feeding running 40 ml per hour and 4 hourly if aspiration is more than 200 ml, it is not the falling of enteral nutrition. So it is a false. And daily calorie intake should be uh, daily calorie intake should be 100 to 130% patient calculated daily energy expenditure is false. Then parental nutrition can be administered peripherally. Yes, we do use. There are two type of parental nutrition available depending upon the osmolality. The central one has a very high osmolar and little high calorie, and whichever given in the peripherally that is low calorie and also low osmolality. And the nitrogen requirement not 1 gram per kg per day. It is commonly mistaken with the protein. Nitrogen requirement is little less. And copper, zinc, selenium, trace element not introduced in the commercially prepared parental nutrition because of the stabilization issue. So your nitrogen requirement is 0.13 to 0.24 gram per kg per day, whereas the protein requirement is equal to 1 gram per kg per day. Regarding the diabetic ketoacidosis can be diagnosed if the patient is diabetic, patient with hyperglycemia, plasma glucose more than 10 millimole, and serum bicarbonate less than 15. The high serum ketone level indicate more severe disease. DK should be treated with fixed rate of insulin infusion, and when managed patient with DK, their usual insulin regime should be stopped, but oral anti-diabetic medication should be continued. DK deemed to be resolved when urinary ketone is no longer detectable. Though it is not directly the nutritional question, but we have put it over here. So from the endocrine, there are four topic is very important. One is addition disease. Second is diabetic emergency, either diabetic ketoacidosis or myxedema coma. And third is the thyrotoxicosis. So the criteria for diagnosis of diabetic ketoacidosis is blood ketone should be more than 6 millimole, or urine ketone 2 plus, and your bicarbonate should be less than 15, and pH should be less than 7.0, and set. These are the major criteria. Along with, you may find that GCS4, hypokalemia, systolic blood pressure low, and there maybe is a high anion gap acidosis you might find. And you have to give the insulin. The management of diabetic ketoacidosis is initially first you measure the potassium. If the potassium is more than 4, then you can start the insulin. If it is less than 4, then 4 milliequivalent per liter, then you have to start potassium replacement first, then you have to start the insulin. And what is the normal requirement? Normal requirement of insulin start zero point 0.1 unit per kg, aiming to reduce the ketone concentration by 0.5 millimole per liter per hour. and your bicarbonate should be increased 0.3 millimole per liter per hour, and reduction capillary blood glucose. Your target is 3 millimole per hour, liter per hour. And always you keep maintain potassium is 4 to 5.5 millimole per liter, because when you will start insulin, there will be intercellular shift of potassium, which might produce the arrhythmia. So that's why you have to keep potassium in the normal range. So if the severe potassium is severely low, then you have to replace the potassium. Along with you have to replace the magnesium and the calcium gluconate. You have to induce it, sensitize the heart, so it prevent your arrhythmia. Regarding the oral medication not in the initial stage. Once the diabetic ketoacidosis resolve, you can use the oral medication. Patient with suspected rhabdomyolysis, the absence of myoglobinuria exclude the diagnosis. Administration of the sodium bicarbonate and the mannitol is the mainstay of treatment. Alkalization of the urine aim to increase stabilize TRAM horsefall protein myoglobin complex. Bicarbonate should be titrated. Urinary pH more than 9. Hypercalcemia is frequently seen in the early stage. So, patient with suspected rhabdomyolysis, the rhabdomyolysis can happen in any cause. It can be happen due to compartment syndrome, due to trauma, and sometime the fever, neuroleptic syndrome is produce rhabdomyolysis, and the what happened in the rhabdomyolysis, there is a edema and there is a breakdown of the muscle protein, and it liberates the myoglobin. This myoglobin bind with the tram horsefall protein present in the plasma, and this produce this tram horsefall protein myoglobin complex, which is ultimately it block the renal tubule and produce the renal failure. So, uh, so the treatment of here is to maintain well hydration, and the sodium bicarbonate should be titrated. The urinary pH should be kept more than 7. It enhance alkalinization of the urine, is increased solubility of the brown granular cast formed by trans horsefall protein and myoglobin complex, which facilitate urinary drainage. That's why you have to give some sodium bicarbonate, and you have to monitor the urine pH. It always should be more than 7. Hypocalcemia often is seen in early stage due to the damaged cell liberate the internal molecule like phosphate is coming outside, and this phosphate chelate with the calcium produce calcium phosphate. So there will be a hyperkalemia, hypocalcemia, and hyperphosphatemia like picture. Regarding the tumor lysis syndrome, high dose intravenous steroid therapy is reasonably initial treatment option. Tumor lysis syndrome is most commonly associated with squamous cell or neuroendocrine tumor. Clinical tumor lysis syndrome can be diagnosed patient with seizure and presence of appropriate laboratory finding, and increased serum calcium and potassium level more than 20 So regarding the tumor lysis syndrome, so what is your answer? Salman, you have given answer of this question. TTFT. So high dose intravenous steroid. What happened in the tumor lysis syndrome? It is most commonly found in the hematopoietic cancer, and where there is a after the first dose of chemotherapy, there is a huge uh, cell lysis happen. So it is like again is like a rhabdomyolysis. When the cell lysis happen, it liberate lot of the intercellular materials, and this intercellular materials contain high potassium, high protein, high phosphate, and this phosphate chelate with the calcium and produces hypocalcemia. So again, and this protein breakdown causing a lot of develop uric acid, uric crystal, which is causing the renal failure. So high dose intravenous steroid therapy is not recommended and commonly associated with not squamous cell or neuroendocrine tumor. It is a uh, CLL, or is a lymphatic cancer where it can be found. And then clinical diagnosis: patients Caesar, patients of appropriate laboratory finding. So your only true here is the clinical TLS can diagnose patient with seizure and patient of appropriate laboratory findings. Seizure, why this seizure happen? Seizure happen because of the electrolyte imbalance, and the laboratory findings mainly your electrolyte imbalance, and the history will suggest that the patient might develop hemolysis syndrome. And uh, tumor lysis syndrome is a life-threatening complication, massive cellular lysis in the cancer cell, most commonly seen in the hematological malignancy. Hypocalcemia is the hallmark, and hyperphosphatemia and hyperkalemia is the electrolyte imbalance, and increase the serum uric acid or increase serum potassium is the baseline, and phosphate also increase more than 25% of the baseline. Drug acting prevent formation of the uric acid is allopurinol, or the drug of choice in the tumor lysis syndrome is rasburicase, which prevent formation of the allopurinol from uric acid. And intravenous hydration and rasburicase is the first line of treatment. And high risk group of patient, uh, and rasburicase is a synthetic urate oxidase enzyme. It's break down uric acid, and along the presence of hyperphosphatemia, the principal cause of acute kidney injury in tumor lysis syndrome. When managing nutritional status of the critically ill patient, which of the following statement is most accurate? The high gastric residual volume should prompt prescribe 7-day prokinetic regimen following exclusion of obstetric cause. Intravenous propofol infusion is provide significant proportion of the daily calorie intake. The MAST scoring tool is a gold standard for identifying malnourished patient. Early parental nutrition should be commenced in patients who cannot meet calorie target by enteral nutrition alone. Early provision of the glutamine antioxidant supplement critically patient improve outcome. So let's see. The only true is the B statement: intravenous propofol infusion provides significant portion of daily calorie intake. So gastric residual volume, I always previously mentioned that there is a no contraindication for uh, no contraindication for enteral feeding if the gastric residual volume is the 500. So you have to give prokinetic and you have to continue the enteral feeding with a lower dose. And the masked screening tool based on the knowledge of the patient body mass index, acute illness status, and evidence of recent weight loss and patient scoring is highly should be more detailed assessment. There are one big trial, EPANIC trial, early versus late parental nutrition trial shows that reduction mortality with late comments of parental nutrition. It has been shown that if you give the early enteral nutrition, it has a good mortality benefit, but if you start early parental nutrition, it can increase the mortality. So next question is, sorry. 78-year-old man has collapsed several hours ago and been found on the floor by paramedics. He was found to be hypothermic at 32 degrees Celsius. His creatinine kinase is 10,000. His serum potassium is 5 millimole per liter. Urea 20 millimole per liter. Creatinine 300 micromole per liter. And the most important form of initial treatment. So here there is a three problem. One is the hypothermia and creatinine kinase CPK is high and serum potassium 5 millimole also high. Urea is little higher side, but creatinine is double the normal. So what will be the initial most important treatment is to manage the hypothermia. So what answer given? The generous IV steroid should be administered. Active warming is important, but intravenous fluid resuscitation should be the first priority. If the patient is actively rewarmed without correcting volume status, they are likely to be precipitate the vasodilation and significant hypotension. Mannitol furosemide may be used to try improve renal perfusion with limited evidence base but no initial treatment. His potassium is above the normal range, may need to renal replacement therapy if it does not correct adequate fluid resuscitation, but the patient does not need urgent hemodialysis. So here the problem is the hypothermia and also the creatinine kinase is high. So might be there is a rhabdomyolysis and probably potassium and creatinine may be high due to that. So the treatment is warming and second intravenous administration of fluid resuscitation. Okay. So then you have the following are complication treatment of diabetic ketoacidosis. Hypomagnesemia, cerebral edema, hyperphosphatemia, hyperchloronic acidosis, coagulopathy. The complication treatment of diabetic ketoacidosis. So it's all are complication, but what is the most common? Yeah. So diabetic ketoacidosis management involve careful fluid resuscitation and electrolyte management. Hypoglycemia is the commonest one for insulin over replacement. Serum phosphate level fall during the treatment when the result of intracellular shift of potassium, and this require daily monitoring appropriate replacement. Serum magnesium may also fall during insulin treatment. Cerebral edema mainly occur in the children, but also can occur in the adult patient due to rapid shift of plasma osmolarity, and this can be present drowsiness, confusion, headache. Such patient require HDU and ICU admission. Observe low threshold CT scan of brain may be needed. Hyperchloremic acidosis can be precipitated if you are giving the resuscitation fluid too much or sodium chloride solution, like which we said that normal saline, though it is no normal saline. The following are recognized cause of normal anion gap metabolic acidosis: ureteroenterostomy, administration of excess normal saline solution, Addison disease, use of carbonic anhydrase inhibitor, and diabetic ketoacidosis. So normal anion gap acidosis, you might know the NAGMA and HAGMA. So high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. You have to mug up this condition causing NAGMA, causing HAGMA, because the question you might get this type, or you might get the scenario with AVG and you have to asks what is the appropriate cause. So ureteroendostomy is when there is a complete bladder resection due to bladder carcinoma, then the ureter implant in the sigmoid colon, and they divert the entire urine from bladder side to the colonic side, and it causes your bicarbonate loses and chloride shift. Therefore, hyperchloremic metabolic acidosis can be developed. Administration at excess normal saline solution also causes the normal solution. How much sodium and chloride content? It is 154 milliequivalent sodium and your 154 milliequivalent of chloride. So if you use as a resuscitative fluid, there is a huge chloride load. Chloride is a strong ion difference ion, negatively charged, and it causes the hyperchloremic metabolic acidosis. This is a normal anion gap acidosis. What happened in the addition disease? Addison disease also, your the addition disease and the carbonic anhydrase inhibitor additionally cause normal anion gap metabolic acidosis. In the addition disease, due to the cortisol deficiency and due to mineralocorticoid deficiency, there is a chance of development of your normal anion gap acidosis. And high anion gap acidosis only here the diabetic ketoacidosis, lactic acidosis, ethylene glycol, salicylate poisoning can produce high anion gap metabolic acidosis. Another question regarding arterial blood gas analysis: the pH of gas sample is directly measured, and all arterial blood gas sample measure 37 degree plus minus 0.1. The blood gas analysis will underestimate the true of vivo PSO2 in hypothermic patient, and bubble of air in the gas syringe will affect partial pressure PO2. Leukopenia can cause pseudo hypoxemia. So the factor affecting the it is a question, is a very basic question. The factor affecting the value of your ABG parameter. It is important topic. You have to know. So, what are the parameter ABG machine directly calculate? One is pH, second in PaCO2, and third is your PaO2. And the bicarbonate and the base axis, even oxygen saturation SpO2, they measure from the directly measured value to they measure the this bicarbonate base axis and the oxygen saturation. And you have to keep the temperature between 37 degrees Celsius plus minus 1.1 degrees Celsius to get a good result. Otherwise, the electrode does not give you the perfect result. And the gas bubble in the syringe can influence the your partial pressure of the oxygen and also in the carbon dioxide. And in extreme leukocytosis, increase the oxygen consumption and it's produce pseudo hypoxia, but in leukopenia, not produce the pseudo hypoxia. The following are recognized cause of isotonic hyponatremia. So this is a when you will get the question from the electrolyte metabolism. So in this segment, hypo or hypernatremia and management, hypo and hyperkalemia diagnosis and management is very important, along with the calcium metabolism. These three iron metabolism you have to mug up before you are appearing for the exam. So hyperglycemia causes hyponatremia. Yes, in the majority patient, hyponatremia in a hypotonic, such as effective osmolality, sodium level are low. The rare case serum containing additional osmol renders serum isotonic and osmolality value approaching normal. Cause including hyperglycemia, mannitol, glycine absorption during prolonged neurological surgery. Cause of hypotonic hyponatremia include syndrome, inappropriate antidiuretic, hormone secretion, psychological polydipsia, cerebral Solvesten syndrome, hypoadrenalism, and hyperpotonemia. So, hypo and hypernatremia and hypo and hyperkalemia. It's a very common topic. You will get a question on that. So following are recommended initial treatment option management of severe symptomatic hypotonic hyponatremia in detrimental onset. So if it is a one-liner question, type A, then administration of 3% hypertonic saline. And so severe hyponatremia, depending upon the symptom characteristic, if there is a seizure, hyponatremia causing the precipitating the seizure, then you have to give the 3% saline in a bolus till the symptom control. It is the intense ESICM recommendation, and also European Society of Endocrinology suggested for more aggressive treatment on symptomatic profound hyponatremia. Okay, and desmospacin is a synthetic ADH you can use, but not in a symptomatic cases. Regarding the diagnosis of diabetic ketoacidosis, the following diagnostic criteria is applied. So it is a old question. I have already mentioned the main three criteria. One is the pH, it should be acidotic. Plasma bicarbonate should be less than 15, or there is a presence of urinary ketone or blood ketone more than 6 millimole per liter. So ketonemia more than 3 millimole, significantly ketonuria, bicarbonate less, and blood glucose more than 11 millimole per liter. Then it is called decay. Thank you, Sana. I have completed one domain.
Sure, sir.
There's another domain. My which is not visible now. So just a minute. My slide is visible, Sana.
Yes, sir. Your screen is visible.
Okay. Now there are a few questions from the general topic. So regarding the general topic, before I'm going to the topic, I want to suggest you something that please read all the score and the parameter like Apache, like your GS, GCS, like your SOFA, and also whatever the score page and CPI index for your pneumonia, CRAF scoring for the pneumonia diagnosis and the management. So whatever the score pageant for every system or every disease have some score. So you go through the scoring system, you might get a question on the score, especially from the GCS score or from your uh, delirium score and the pneumonia index score or CRAF 65. These are the very important scoring system. And again, you have to know the classification of the shock and hemorrhagic shock when it is category 1, category 2, category 4. You have to identify the question they will formulate like that. You have to identify the which category in your patient, and also you have to know some knowledge about the triage, because question coming from the triage in a trauma question. Now coming to rationale of potential cannot intubate, cannot ventilate scenario, anesthetic practice, and it is estimated it occur 0.01 to 0.2% per 100,000 cases. Jet ventilation is required for kicothyroidotomy with cannula more than 4 mm diameter. Over 90% of cannot intubated, cannot ventilated situation are preventable, and fixation error may lead to loss of situational awareness and poor decision making. Ecothyrotomy skill are retained for only a short period. So it is again K-type question. So cannot intubate, cannot ventilate
That was a button
scenario,
foot.
Oh, because I kind of put it on McDonald's.
Is it?
endotracheal tube.
I'll eat it later. You buy the those drinks.
Yeah. Sir, number
Yeah,
225.
I'll have it.
Okay.
Sana,
Yeah,
can
when
you
it comes,
please
please add later.
Yaru.
mute?
Yeah.
Sana, please mute.
Maybe we don't start talking.
Hello. Okay. So your so jet ventilation requirement kicothyroid cannula 4 mm diameter. No, it should be more than 4 mm diameter. And data suggests that more than 90% cannot intubated, cannot ventilated scenario we can prevent. That's why there is a difficult airway algorithm is there, and you have to be prepared before dealing in the difficult intubation patient, and even also it's considered that difficult intubation, both it can be anatomical difficulty or it can be physiological difficulty in our ICU patient. It considered that there might be anatomical difficulty because you are not able to do the scoring. But each and every patient is a physiological difficulty in a ICU because there is a oxygen reserve is very less, and also the their chance of hypovolemia and hypotension during the intubation and the post-intubation. So adequate fluid resuscitation, volume status check is mandatory before you are putting the tube or you are giving any sedative drug. And next options fixation is trying achieve endotracheal tube at all costs. Presence of trying airway method is already failed, results significant human error, loss of situational awareness, poor decision making. And your skill of kekothyroidectomy is short period, so you have to do regular basis, at least within 3 months or to 6 months you perform one kekothyroidectomy, then you can maintain your skill. Concerning heparin-induced thrombocytopenia, the platelet count typically fall 30 to 50% within 5 to 10 days. Another important area is heat, heparin-induced thrombocytopenia. In part 1, EDIC question, an incident 10x higher in unfractionated versus low molecular weight heparin. It is more common in male patient. IgM antibody, heparin P4 antigen occur in the surface of the platelet, and danaperoid has been used successfully in heat-induced thrombosis. Now, what is heat? The heparin-induced thrombocytopenia is typically developed within 3 to 4 days of heparin injection for anticoagulation use, and it is very common when there is a before exposure within 3 months, the heparin uses. And what happened here? The heparin bind with platelet factor 4, PF4 molecule, and they produce the heparin factor 4 complex in the platelet. And when there is a and it is a immunogenic, and it produces the antibody. This antibody is generally IgG antibody, and when this IgG antibody bind with heparin P4 antigen, it activates the platelet aggregation, and it produce more and more P4, and which bind to the heparin and produce this active complex, and it produce thrombosis and consumption thrombocytopenia. So treatment is avoid heparin. You use danaperoid, or you use fondaparinux, the other anticoagulant. And heparin has a highest incidence of heat, but low molecular weight heparin can also produce the heat. And generally, heat is very common in the female population. Regarding the larynx in adult, it extends up to C3, C6 midline. External branch of superior laryngeal nerve innervated the kekothyroid muscle. Superior laryngeal nerve is a branch of vagus nerve. Damage of external branch of superior laryngeal nerve resulting in cadaveric vocal cord position, and tracheostomy is performed through the kekothyroid membrane. Not tracheostomy is not performed by the kekothyroid membrane. Kekothyroidectomy done by the kekothyroid membrane. So let's see, larynx is extended from C3 to C6. Yes. Damage may occur during surgery such as thyroidectomy, causing loss of cord tension and hoarseness. And the superior laryngeal nerve is a vagus nerve, branch of vagus nerve, passes deep to the internal and external carotid artery before dividing into the external and internal branches. And recurrent laryngeal nerve also the branch of vagus nerve, and provide motor innervation of all intrinsic muscle of the larynx except kekothyroid, and sensory innervation below the vocal cord. Bilateral palsy result total loss of the vocal cord function, and it is a cadaveric position midline of the vocal cord. And kekothyroidectomy performed in the emergency situation to the kekothyroid membrane. Tracheostomy is performed between first and fourth tracheal ring. Relation of ethylene glycol poisoning. It may present in the acute ascending motor sensory neuropathy. Normal anion gap acidosis usually is no, it is always high anion gap acidosis. Alcohol dehydrogenase catabolize the metabolism of ethylene glycol to metabolite includes oxalate and glycolic acid. Hemodialysis is not effective. Hemodialysis can be effective. Fomepizole is potent inducer of alcohol dehydrogenase and effective treatment. So, ethylene glycol poisoning present in the three phase depending upon the timing of initiation. First 30 to 60 minutes after ingestion of the acute intoxication occur and which may be result of excitatory syndrome, cerebral edema, convulsion, coma. Second phase between 12 to 18 hours, predominantly cardiovascular symptom, dysarrhythmia, cardiac failure, and profound metabolic acidosis often cause death during this phase. Phase 3 occur in 2 to 3 days, predominantly renal failure and acute tubular necrosis due to calcium deposition. And finally, delayed neurological phase can occur 5 to 20 days post ingestion. Presenting the neurological effect include profound limb weakness, cranial nerve palsy, sensory disturbance. Ethylene glycol cause increased anion gap metabolic acidosis and other factor causing high anion gap metabolic acidosis. One is diabetic ketoacidosis, alcohol poisoning, and your paracetamol poisoning, ethanol, ethylene glycol, methanol, and also isoniazide and iron overdose. Normal anionic gap metabolic acidosis, gastrointestinal losses, diarrhea, and loss of bicarbonate, renal tubular acidosis, renal failure, and hyperchloremic acidosis. The enzyme alcohol dehydrogenase catabolize metabolism of ethylene glycol into toxic metabolite include glycoaldehyde, glycolate, formate, oxalate, glycine, hippuric acid, and benzoic acid. Oxalate may combine with ionized calcium, resulting in hypocalcemia, renal failure due to this oxalate calcium crystal deposit. Ethylene glycol toxic metabolite are responsible for profound high anion gap acidosis associated with toxic sign and symptom. So, renal replacement therapy is very effective in ethylene glycol poisoning. Homozymyl, potent inhibitor of alcohol dehydrogenase, prevent production of the toxic metabolite of the ethylene glycol, and it gives us a loading dose 15 ml per kg or then 10 ml per kg every 12 hours to next 48 hours. So you can use incremental doses. If fomepizole is not available, you can use the ethanol, which metabolite is not toxic. So what happen in an alcohol has a particular pharmacokinetic property. If the concentration is higher and like ethanol is easily metabolized, more affinity with the alcohol dehydrogenase enzyme. So ethanol metabolized faster and the concentration of ethylene glycol same in the blood, but it excreted through the urine. So if fomepizole is not present, then you can give ethanol. In relation of Glasgow Coma Scale, it is incorporated in acute physiology and chronic health evaluation to Apache 2 scoring system. The 4 score is interior of GCS and it can carry out when the patient intubated and ventilated. Score 8 or less considered coma where airway reflex may be inadequate, may be prognosticate significance after traumatic brain injury, and patient who is opening eye on pain and mumble sound and withdraw painful stimulus, the score is 9 by 15. So anybody can volunteer. The result is a again TTFF question. So it is incorporated in the Apache 2. Yes, the 4 score is in inferior to GCS. It can be carried in patient with intubated ventilated, and score 8 means yes, patient is in coma, airway reflex we have to check, and patient might need intubation. And yes, it help in prognosticate. So there are another score where GCS is incorporated, like SOFA score, MOD score, and full assessment of the coma GCS cannot be done. Patient intubated and ventilated to score full outline responsiveness score, replace verbal scoring of GCS, and observe brainstem reflex and becoming the more commonly used. Its score, each component is eye response, motor response, brainstem reflex, and respiration from 0 to 4. Score 8 or below is a deemed to be a significant coma. So airway control protection is very important. And pre-intubation following traumatic brain injury has a prognostic significance in GCS. And last one is very important. What is the score? Score is 8 because there is a eye opening with pain means 2, and there is a mumble sound is 2, and your withdrawal to pain is M4. So 422 means 8. So you have to mark up the GCS scoring each component. Kicothyrotomy, surgical or cannula, esophagus may be damaged. Yes, if you do blind, if you injure the posterior wall, the esophagus is adherence with the posterior wall. You can do injury. There is a low incidence of complication. No, it's a moderate incidence. Is around 20%. Narrow bore cannula kicothyrotomy is suitable for complete upper air occlusion or no. Don't use narrow bore cannula because what happened when it you can do oxygenation, but ventilation will be hampered and may cause barotrauma. Surgical kicothyrotomy has high success rate in anticipated difficult airway, and technique should be abandoned if bleeding occur. Yes, surgical kicothyrotomy is a gold standard, and technique is recommended for identification of the kicothyroid membrane, stab the incision, enlargement, and blunt dissection, and caudal traction, and you put the tracheal tube. The hemorrhage is likely, particularly with wide bore airway. Insertion should be completed quickly, and once you're putting the tube, it has a tamponade effect. Management of the tracheostomy and the laryngectomy in emergency. So if the patient is making spontaneous breathing effort, hand ventilation using Mapleson C circuit should be used initially to assess tracheostomy patency. No, tracheostomy patency is checking by two things. One is the gold standard is the capnography. If you don't have the capnography, you can put the catheter on it, pass the catheter. You will understand that whether your tracheostomy tube in the play, or there is a pseudo tunnel, or there is a blockage in the. If there is a blockage and you do the AMBU or you do the Mapleson C, use the Mapleson C circuit, there is a chance of development of the barotrauma. Suction catheter should be used as a tracheotomy patency. You can. Laryngeal mask over stoma site is inappropriate for ventilation. No. Sometimes we use the mask ventilation in a tracheostomy patient. That is, we use the laryngeal mask ventilation. Size 7 cup endotracheal tube should be used in the intubation of the stoma. No, if the tracheostomy stoma is there, then it is better to use the smaller size. So size 6 with cup is recommended for use. Therapeutic hypothermia, another important area of the therapeutic hypothermia, where you can get the hypothermia itself is a very common topic because in the Western country they got a lot of hypothermic patient. So therapeutic hypothermia indication in acute cardiac arrest to prevent the you protect the brain. You can do the therapeutic hypothermia. Why it is important? Per degree Celsius of body core temperature decrease, it decrease metabolism around 7%. So if you can decrease the requirement, then you can protect your brain. And can cause insulin resistant hypothermia. Yes, it cause the insulin resistant. Cooling decrease metabolism 30%, no, the 7% per degree Celsius. And risks of ventilator tachycardia arise, temperature less than 32, no. When the temperature you reduce more than 28 degrees Celsius, then there is a chance of VT. Myocardial contractility decrease the most patient. Yes, initially it increase the myocardial contractility, but if it is more hypothermic, then there is a decreased myocardial contractility. And remember one thing, when you are doing the therapeutic hypothermia, you have to prevent severing, because severing it increases the oxygen consumption. And also you have to check the your INR to prevent coagulopathy. PT-INR is important. Regarding intra-abdominal compartment syndrome, so normal intra-abdominal IP is 12 to 15, no. It is around 5 to 7. The classified into 4 grade of World Society Abdominal Compartment Syndrome. Yes, the 4 grade 1, grade 2, grade 3, grade 4. Grade 1 is 12 to 15. Grade 2 is 16 to 20. 20 to 25 is the grade 3, and more than 25 with organ failure is the grade 4. Intravenous pressure measurement 0 at iliac crest and mid axillary. Intravesical pressure, yes. There is no direct measurement method. The indirect measurement method, what we do, we put a triple lumen Foley's catheter, and we put the transducer one, and second one we use the 30 ml syringe, and then we check the vesical pressure. It is a surrogate marker of intra-abdominal pressure. And so intra-abdominal pressure and intra-abdominal perfusion pressure, how much in the, so abdominal perfusion pressure should be maintained below 50, no. Abdominal perfusion pressure is a pressure, abdominal perfusion pressure is the pressure which is needed to make transfusion and make the transfusion of the organ. So organ perfusion maintained with the abdominal perfusion pressure, it is around 60, and the formula of the calculation is mean arterial pressure minus your intra-abdominal pressure equal to your abdominal perfusion pressure. So you have to keep more than 60, then your organ perfusion will happen. Last one, acute abdominal compartment syndrome can state following surgical decompression post-operative open abdomen. Yes, if there is a severe abdominal compartment syndrome, then you can do laparotomy, and you can keep the abdomen open. Usually in my hospital, we regularly see when the patient develops acute abdominal syndrome, they can do. Okay. Now coming to the detection of the fluid responsiveness. Clinical assessment, good value detection, fluid responsiveness, static marker, preload, central venous pressure, and pulmonary arterial occlusion pressure predict fluid responsiveness reliable. Validation in arterial pulse pressure can predict fluid responsiveness in a ventilated patient. Arterial pulse pressure variation cannot be used as a fluid responsiveness spontaneously breathing patient, and passive leg rising may aid predict fluid responsiveness spontaneously breathing patient. So let's see. Uh, Clinical evaluation patient poor unreliable indicator of fluid need and fluid responsiveness, though it remain integral and overall assessment. But the recent study said that your capillary refilling time, urine output is as good as your check the patient having fluid deficit or not. And central venous pressure, pulmonary wedge pressure predicted fluid responsiveness poorly, and trend analysis may be useful. There is no static marker in ICU. Always you have to have dynamic marker. So how will you detect your patient is fluid responsiveness? By checking the IVC collapsibility index or your patient VTI. So VTI is the gold standard. Variation in arterial pulse pressure can predict fluid responsiveness in ventilated patient. Yes. Uh, if there is a variation in the pulse pressure in a ventilated patient, the condition is to be ideal. Patient should be sedated and paralyzed, and tidal volume should be 8 ml per kg. If there is a variation in the pulse pressure, it is why it is happens. It is very normal when there is a inspiratory inspiration due to the mechanical ventilation create a positive pressure ventilation, and when there is a inspiration, what happen in the heart, there is a squeezing of the vessels causing left ventricular preload is high, so left ventricular output is high, but at the same time it increases the intrathoracic pressure, so it reduces the venous return. So subsequently there will be a uh, low venous return, low preload, and low your cardiac output. So there will be a big spike followed by the small spike in the arterial arterial tracing, and this is actually called pulse pressure variation. And when there is a pulse pressure variation, if it is more than 10%, so your patient is fluid depleted, need fluid responsive, fluid needed. The arterial pulse pressure variation can be in the spontaneously breathing patient. In spontaneously breathing patient, also you have, if this variation, you can find out, but sometimes it is difficult. Passive leg rising may add predicted fluid response in spontaneously breathing patient. Yes, passive leg rising PLR test is also give you the idea. Basically, when you are doing the passive leg rising, and if you measure the VTI, so your the lower part of body content is more than 500 ml of blood. So when you are putting the 45-degree angle of the leg, there will be increased venous return, will subsequently increase your uh, preload. So it increase your VTI. So it is it can be your marker for check the fluid responsiveness. But what is the advantage of the PLR test? You are not putting any extra fluid from the outside. So it is very useful for patient, particularly like patient having DCM or patient having CKD. where the fluid restriction is very important. So in that category of patient, it is very useful. And now coming to the hypertonic saline, 7.5% sodium chloride content. This is a simple formula, and draw interstitial intercellular water into the intravascular space, decrease cerebral swelling, intracranial pressure, and 250 ml 7.5% chloride is inadequate initial resuscitation dose, may cause severe hyponatremia. So hypertonic saline 7.5% contain 1283. Hypertonic saline draw interstitial, and because it has a very high oncotic pressure or osmolality and is draw the fluid. Hypertonic saline decrease cerebral swelling in ICP. Yes, it has been used nowadays in the neuro ICU, and small volume of hypertonic fluid, example 250 ml 7% chloride may adequate for initial resuscitation dose. No, may cause severe hypernatremia, not hyponatremia. Regarding the humidification, absolute humidity is defined the weight of the water vapor contained in given volume gas, and relative humidity is contained water in the air in the specific temperature compared to capacity of the water that air can hold the same temperature gas arriving. Regarding humidity HME filter, you might get this type of question. This is actually a real question from the past EDIC exam. So please read about humidification very carefully. It is very important topic. So absolute humidity is definition, and the relative definition is obviously it is true. But the nose can humidify air up relative humidity up to 60%. No. Hydroscopic heat and moisture exchanger filter are the bacteria. Moisture exchanger filter bacteria. Yes, this is hydrophobic, not hydroscopic. It is a hydrophobic. So you see that it changes word and make the difference. The following are example of severity scoring system in intensive care unit: Apache 2, CT calcium score, SOFA score, mortality predicted model, and Glasgow Blatter score. So Apache, yes. CT calcium scoring for severity scoring, I have not heard about. SOFA score, yes. And mortality predicting model, yes. But this is Glasgow Whitford score is used for your uh, risk stratification of the upper gastrointestinal bleeding, whether there is a chance of rebleeding or not. But it is not a directly mortality score. It is a in prognosticate score of endoscopic intervention. And regarding the prevention of the grading pressure ulcer in the critically ill, pressure shear fiction all require a pressure ulcer to develop, and Waterloo score is used to grade pressure ulcer, and all grade 1 pressure ulcer have intact skin. Apache 2 score correlate well. Occurrence of pressure ulcer and critically ill patients should be turned every 2 to 3 hours to prevent development pressure ulcer. So pressure ulcer, the pressure ulcer defines the area localized damage of the skin and underlying tissue caused by pressure, shearing, friction, and combination of these. There are multiple risk factors for developing pressure ulcer. The most important thing that subcutaneous tissue, how much subcutaneous tissue is there, and your Apache is not directly for the pressure ulcer, And SAPS to score customize geographical region. No, SAPS to is not for the pressure ulcer. And the SOFA, what is said, increase SOFA score during the first 48 hours of predicted mortality at least 50%, yes. And therapeutic intervention scoring system is nursing workload, yes. So guys, please go through the different scoring system, and I mention about that. So very important scoring is the Apache SOFA mail score, and also the pneumonia related ARDS related scoring system you have to go. Thank you. Uh, Padma, can I quit? I have some urgent work.
Well, sir, thank you very much for taking a session on Sunday, and all the best to all the aspirants who are appearing for the EDIC Part 1 examination. Thank you all. Thank you,
Thank
sir.
you all. If you have any doubt on any years, Fatma might have created a group. You put your question in the group. I will be in the group. Fatma, include me in the group. So
Sure,
it
sir.
is not that one or two lecture in the crash course. Farz Academy always be part with the student till their exam over. So our all faculty will be with you, and will we will help you out. If any doubt in any topic, you have a doubt, please feel free to put up the question in the group. We will try to solve it out, and we will try to uh, give you the answer, and keep us updated uh, about your preparation, about your weakness. If you need any further session, particularly for me, I am always ready to take this part. And sorry, today I have a little rush to do lot of work, so I'm stopping here. Thank you. Thank you.
Thank you, sir, for your valuable time.
And Padma, please keep a group. Okay.
Sure, sir. Sure. I will create one.
Thank you.